So good night, everyone. I'm Regine Lavelle, and tonight I'll be presenting part two of my presentation, which is the final part, and we'll be talking about spinal vascular disorders. So tonight we'll talk about the basic anatomy of the spinal cord vasculature, classifications of spinal vascular disorders, general presentation, imaging, treatment. We'll touch on neoplastic lesions related to the vascular system, as well as the rare occurrence of spinal cord aneurysms. So we'll get into the anatomy first, and we'll talk about the arterial system. So although a radicular artery from the aorta accompanies the nerve root at many levels, most of these have very little contribution to the spinal cord itself. So the anterior spinal artery, which you can see in the axial schematic, is formed from the junction of two branches, each from one of the vertebral arteries. It supplies blood to the anterior two-thirds of the spinal cord. And branches of this include sulcal arteries, which also supply the anterior horns of the gray matter. Major contributions to the anterior spinal cord are from 6 to 9 radicular arteries. It varies. And some of these, and you can see these in the sagittal view or the image on the right. So the radicular artery at C3, which arises from the vertebral artery, C6 and C8, approximately 10% of the population lack the anterior radicular artery in the lower cervical spine. C6 arises from the deep cervical artery and C8 from the costocervical trunk. And then there's radicular arteries at T4 or T5. Then of note is the artery of Adamkiewicz, right? Also known as the arteria radicularis anterior magna. And this is the main arterial supply for the spinal cord from approximately T8 to the conus. Is located on the left side in 80% of the population, leaving 20% on the right. And situated, the level changes. So it's situated between T9 and L2 in 85%, T9 to T12 in 75% of that 85%. And in the remaining 15%, it occurs between T5 and T8. And in these cases, there may be a supplemental radicular artery further down. Usually the artery of Adamkiewicz is fairly large and gives off cephalic and caudal branches, the latter of which is usually larger. And on angiography, it gives a hairpin appearance. So continue the arterial supply. Opposite to the anterior spinal artery, the posterior spinal arteries are paired. So there are two posterior spinal arteries and are fed by 10 to 23 radicular branches. Anastomotic vessels between the anterior and posterior spinal arteries are called vasocorona. Of note, as you can see on the image on the right, the mid-thoracic region has a tenuous vascular supply known as the watershed zone. And this is the area of the spinal cord that is more susceptible to vascular insults. Just to note an anatomic variant known as the arcade of Lozorth, which is an normal anatomic variant of the Adamkiewicz artery. It is where the anterior spinal artery joins the paired posterior spinal arteries. And then the venous system of the spinal cord, it could be divided into the intrinsic and extrinsic. So intrinsic venous system refers to the collecting veins within the spinal cord parenchyma. And then the PL venous network, radicular veins, and the longitudinally oriented anterior and posterior spinal veins comprise the extrinsic system. The anterior spinal veins are paired and course from the medulla oblongata to the phalanx terminale. There are numerous ventral and dorsal radiculomedullary veins, which collect blood from the anterior and the posterior spinal veins. And these course with the nerve roots, but don't drain them. The largest radiculomedullary vein is called the great anterior radiculomedullary vein, and drains the thoracolumbar cord. It can be mistaken for the artery of Adamkiewicz due to its size and the location. So these radiculomedullary veins then empty into the internal vertebral plexus of the extradural system. The vertebral venous plexus is also called the Barton plexus. It has the internal, external, and basivertebral plexus, and the anterior and posterior external vertebral plexus then enter into the systemic veins. So now we can get into the spinal vascular disorders or malformation, which are rare and still very underdiagnosed entities. If not treated properly, can lead to considerable morbidity and progressive spinal cord symptoms. The clinical diagnosis rests mainly on MRI, but for a thorough understanding of the disease, as well as for planning of therapeutic strategies, DSA is still necessary. So subtraction angiography is still necessary. Depending on the type of spinal vascular lesion, initial symptoms may vary between acute or chronic. Pathophysiologic mechanisms include intramedullary or subarachnoid hemorrhages or subacute venous congestion, which leads to progressive myelopathy. So some of them have a space-occupying nature and a circulatory steal phenomena, which could also add to the pathophysiologic mechanisms. Often also, the spinal vascular disorders are often also referred to as spinal AVMs, which technically refers to a subset of the spinal vascular disorders. Incidence of SVMs is about 4% of primary intraspinal masses, and 80% occur between the ages of 20 to 60 years of age. So some of the disorders we'll be talking about are AVM, so arteriovenous malformation, arteriovenous fistulae, spinal neoplastic vascular lesions, which include cavernous malformations and hemangioblastoma, and then we'll touch on spinal aneurysm, which is very rare. So we'll go through the classifications first. So there are three current era classification systems. The classic one, which we'll be focusing on mainly for this presentation, is the American English-French connection classification, then the Hôpital-Bicêtre classification, and finally the Spezler classification. So the classic divides the malformations into types 1, 2, 3, and 4. So type 1 is a dural AVM, also known as dural AV fistula. It's the most common type. 80% accounts for 80% of SVMs in the adults. It's fed by a radicular artery, which forms an AV shunt at the dural root sleeve and drains into an engorged vein that connects to the venous system and the posterior cord. It usually occurs in the lumbar or the lower thoracic spine and is of slow flow. High pressure in the vein and the draining veins causes venous congestion of the cord, and typically an MRI will show, and I will show an image of this later on, spinal cord edema and flow voids and or serpiginous vessels on the surface of the cord. Cord involvement may be distant to the fistula, and symptoms would include lower back pain, progressive myeloradiculopathy, or cauda-equina syndrome due to the venous congestion. It usually occurs in middle-aged patients, 90% of which are males, and up to 35% of these patients have pain. They tend to be associated with other AVMs. And then 2, we have intradural AVMs, which are high flow, and these include types 2, 3, and 4. So type 2 is also known as spinal glomus AVM, and it's intramedullary. It is what is considered a true AVM of the spinal cord and accounts for about 15 to 20% of SVMs. It has a compact nidus fed by medullary arteries with the AV shunt contained at least partially within the spinal cord of Pia. It may be associated with feeding artery aneurysms, and it has a worse prognosis than type 1. Type 3 is also known as juvenile spinal AVM. Essentially, it's a large type 2, so enlarged glomus AVM, which occupies the entire cross-section of the cord and invades the vertebral body, which can cause scoliosis. Then type 4, intradural perimedullary AVM, also called the arteriovenous fistulae, is a direct fistula between the artery supplying the spinal cord, usually the adunculates, and the draining veins. They tend to occur in younger patients as when compared to type 1, and may present catastrophically with hemorrhage into the subarachnoid space. So type 4 has 3 subsets, A, B, and C. And this table just summarizes how they are classified. So type 1 is a single and thin. The AVF is small, and The venous drainage is a slowly ascending perimedullary venous system. Types 2 and 3 have multiple. For type 2, the AVF can be multiple, medium-sized, and also has a slowly ascending perimedullary venous system, whereas the subset 3 is single, giant, and the venous drainage is a giant venous ectasia with rapid metameric venous drainage. In addition, there are miscellaneous lesions, so spinal cord cavernomas, spinal cord venous angiomas, and vertebral body hemangiomas. So as I was speaking about before, the image, the MRI on the left just shows a dural AVM with spinal cord edema pointed out with the white arrow, and flow voids pointed out by the yellow arrows, as well as serpiginous vessels, which is not very clear in the image. This MRI shows a typical glomerular, so type 2 AVM. Next classification is Hôpital Bicêtre classification, and it's grouped into 3. So 1, AVMs, 2, fistulae, so it could be micro or macrofistulae, and 3 comprises the genetic classification of spinal cord AV shunts, 1 being genetic hereditary lesions, so macrofistulae and hereditary hemorrhagic telangiectasias. B, genetic or hereditary lesions, so multiple lesions with metameric or myelomeric associations. And then C, single lesions, which could be incomplete associations of categories A or B. This image shows macrofistulae, so you have the MRI on the left and then angiography on the right. Finally, we have the Spatula classification. This is a little bit more complicated, and it's reincorporated vascular spinal neoplasms. So 1, we have the neoplastic vascular lesions, which include the hemangioblastoma and cavernous malformation. 2, we have spinal aneurysms, which are rare. And then 3 include the arteriovenous lesions, so AVFs, which can be extradural or intradural, and arteriovenous malformations, which are extradural, intradural, intramedullary, extramedullary, and conus medullaris. So as I mentioned, we'll be referring to the first classification mainly that I talked about, so types 1, 2, 3, and 4. Presentation of these patients. So 85% present as progressive neurodeficit, so back pain associated with progressive sensory loss and lower extremity weakness could be occurring over a period of months to years. SVMs account for less than 5% of lesions presenting as spinal cord tumors, and 10 to 20% of SVMs present as sudden onset of myelopathy, usually in patients less than 30 years of age, as I touched on before, secondary to hemorrhage causing subarachnoid hemorrhage, hematomyelia, epidural hematoma, or watershed infarction. Clinically, auscultation over the spine can reveal a bruit in about 2 to 3% of cases. And then cutaneous angiomas over the back is present in 3 and up to 25%. Valsalva maneuver may enhance a cutaneous angioma presentation. 2 terms to know are coup de poignard of Michon, which is just, and forgive my French, is sudden excruciating back pain with subarachnoid hemorrhage and is clinical evidence of an SVM. And then 4, Alajuanine syndrome, also known as subacute necrotic myelopathy, which presents as spastic progressing to flaccid paraplegia with ascending sensory level and loss of sphincter control. Initially, it was thought to be due to spontaneous thrombosis of the AVM leading to subacute necrotizing myelopathy, which would be irreversible. However, more recent evidence suggests that the myelopathy may be due to venous hypertension with secondary ischemia, and therefore improvement with treatment would be possible. Aminoff-Loeb disability scale is a grading used. So initially, it was used for the rating disability of gait and micturition related to spinal dural AVS, but now it has been validated for prognostication. So gait disturbance has a score of up to 5, and bladder function has a score of up to 3. 0 to 3 score indicates a 78% chance of substantial improvement. A score of 4 to 5 is a 29% chance of substantial improvement, while a score of 6 to 8 gives an 11% chance of substantial improvement. Evaluation of spinal AVMs. So spinal angiography, as I mentioned when I started, is necessary for treatment planning. For type 1 dural AVMs, the fistula occurs in the nerve root sleeve. So before it can be considered negative, angiography must encompass all dural feeders of the neuroaxis, which would include the internal carotids, every radicular artery, including the artery of Adamkowitz, and the internal iliac arteries. Now, MRI detects some SVMs with greater sensitivity and safety, in particular, than angiography, but it is inadequate for treatment planning. 82% of the MRIs would show extramedullary flow voids. I showed that in the image prior, the MRI prior. Spinal cord edema is common, and cord enhancement from venous congestion or venous infarction would be variable. Note well, a negative MRI does not rule out a diagnosis. Myelography generally is superseded by MRI. It classically shows serpiginous intradural filling defects. If done, the patient would have to be imaged prone and supine to avoid missing a dorsal AVM, and tends to be avoided because there's a risk of significant bleeding if the myelography needle punctures a dilated artery or vein. So treatment generally. Now, variable neurological symptoms and complex angioarchitectures make spinal AVM a very challenging clinical entity. Is important. Classification is very important because classifying the spinal AVM cases based on angiographical characters is important for selecting the proper surgical and endovascular treatments. So there has been introduction of neuromonitoring, indocyanine green video angiography, three-dimensional fusion images, and the use of endoscope, which has made surgical intervention a safer and more reliable option for these cases. And in endovascular treatment, embolic materials and techniques are continuously improved over the past few years. Advancement of surgical and endovascular treatments can improve current treatment strategy, and neurosurgical and endovascular teams, as with everything that is complicated, should collaborate to choose an appropriate treatment for individual cases. So for type 1, dural AVFs usually require treatment. The goal here is to interrupt the feeding vein close to the nidus, which is located in the nerve root sleeve. Therefore, the vein should be sacrificed close to where it enters the dura of the thecal sac. Some are amenable to endovascular techniques using glue, in which case the proximal draining vein must be taken as well. Localization of the nidus at surgery is facilitated by placing a coil in the feeding artery at the time of angiography, which is then easily located on fluoroscopy at the time of surgery. Once identified, the vein is coagulated and divided. Some dural AVFs have extradural venous feeders as well. Conventional intraoperative angiography and indocyanine green angiography assist in confirming the elimination of the dural AVF. And this is important because if a dural fistula is not completely eliminated, it will come back. Type 2, so spinal glomus AVMs, they may be amenable to interventional neuroradiological procedures. This includes embolization, particularly the type 2A or single feeders. However, in type 2B, recurrence may be higher with endovascular treatment, and so surgery is preferred for type 2B malformations. The surgical strategy for these spinal AVMs is similar to intracranial AVMs, except that the parenchyma cannot be retracted. Bleeding is rarely life-threatening. Intraoperative, again, angio is often helpful. The nidus is compact, and the hemosiderin ring around the nidus on MRI often gives an idea of the plane that can be exploited. So for type 3 juvenile malformations, the optimal treatment remains to be established. Complete obliteration of fistulas is not always possible because of the complexity and diversity of these AVMs. Therefore, the intervention here is aimed at halting the progression of neurological symptoms and minimizing neurological sequelae. So in other words, the natural history of these AVMs is probably better than the prognosis with any type of treatment. This table summarizes the treatment approach for type 4 arteriovenous fistulae. So for subtype 1 or A, as I described it as above, diagnosis is difficult, the reliability of MRI is questionable, embolization is difficult, and surgery is easy on the phylum terminally. For subtype 2 and 3, diagnosis is relatively easy when compared to type 1 and done with MRI or myelography. For subtype 2, embolization results in incomplete occlusion and surgery is done on the posterolateral AVFs. For subtype 3, embolization is quite effective and surgery can be difficult and dangerous. So a bit on spinal neoplastic vascular lesions, and we will have a lecture on spinal tumors later on, but as it relates to the vasculature, I'm touching on it. So spinal cord cavernous malformations, we'll do those first, and they may be intramedullary, and that is shown in the MRI on the left of the screen, or they can be epidural, shown in the image on the right. Epidural cavernous malformations are rare. And in the intramedullary lesions, indication for surgery is similar to the indications for brainstem cavernous malformations. Next, we have spinal hemangioblastomas. So these are vascular tumors that can be found throughout the neuraxis, as we already know, primarily in the cerebellum and spinal cord. Hemangioblastomas of the spinal cord account for about 3% of all intramedullary spinal tumors. They tend to occur more commonly as sporadic isolated lesions, so is sporadic in 70 to 80% of cases, in contrast to occurring as multiple lesions in cerebellum and retina as part of von Hippel-Lindau disease, which occurs in 16 to 25% of cases. Although hemangioblastomas are histologically benign, they can cause significant neurologic deficits depending on their location. And finally, to end, we'll talk about spinal aneurysms briefly, which are very rare culprits of subarachnoid hemorrhage with different morphological features than their intracranial counterparts. Associations with concurrent vascular lesions and vasculopathy are frequent, with a minority of the cases of spinal aneurysms being isolated in etiology. Magnetic resonance imaging and DSA of the spine delineate the location and vascular anatomy of a spinal artery aneurysm, which is key in management planning. Surgical treatment for these should be prompt and performed cautiously, considering that substantial neurological deficit can result when the arterial supply of the cord is jeopardized. And this image just shows MRI images from a case report of an isolated spinal artery aneurysm. And the aneurysm was confirmed by surgical exploration. From MRI, only differentials could be deduced, but it was confirmed on surgical exploration in this case. So that takes me to the end of my presentation. These are the references I used, and thank you very much for listening. I welcome questions, comments.